Okay, so we were now about to talk about, we really took a lot of time to discriminate between tonicity and osmolality. Um, and now we're going to discuss the effector mechanisms of modifying water balance. And the main effector mechanisms are thirst and vasopressin or antidiuretic hormone. Okay, so let's talk about some of the physiology that underpins these effector mechanisms. Okay, so there is, let's remember the anatomy, I suppose it's worthwhile to talk about. Um, you can see in the essentially the back of the third ventricle of that is the area of the hypothalamus that has osmoreceptors in it. Right, here's the posterior pituitary on the back here, but I have osmoreceptors cells that respond to tonicity with changes in size, and in response to that change in size, they can regulate the release of ADH, right? They have cell bodies which traverse the pituitary stalk into the posterior pituitary and then can release ADH in response to hypertonicity. So hypertonicity makes this cell shrink. The response of that cell in that physiologic state is to say, okay, it's time to release some vasopressin. Okay, these osmoreceptors are also very, or this cluster of osmoreceptors is also regulating thirst similarly, right? But those cell processes are going to the brain to regulate thirst in response to changes in tonicity. Okay, so let's go to, again, a model of human disease, which often gives us some physiologic insights. There is a condition called adipsic diabetes insipidus that can result when I have a lesion in this part of the brain that knocks out my thirst center, right? I'm not stimulating thirst in the setting of hypertonicity, as well as my uh, neurons that extend into the posterior pituitary that allow me to regulate water balance through ADH. So there are patients out there with brain lesions that have no thirst, as well as a central DI. Those are patients that are really difficult to manage. Okay, so that hopefully gives you again a sense of the anatomy. We can now talk about some specifics of these effector mechanisms. Again, these are made, the ADH is made by or cell bodies that exist in the hypothalamus and extend down to the posterior pituitary. They respond to tonicity, right? And once that tonicity, which the only way that we can approximate tonicity is through measurements of osmolality, which are not the same, right? But if we were to use osmolality as a surrogate of tonicity in a euglycemic patient who is not azotemic, we can generalize, or we can accept this statement that vasopressin is released in the normal individual once my osmolality is increasing above 280 or so. Now, everybody has a little bit of a different set point. We have some individuals out there who have the so-called reset osmostat, who can start releasing vasopressin at lower osmolality. And so they have a chronic sodium of 130, right? And are usually asymptomatic. They're just defending a different set point than a normal individual, okay? And that is a threshold that occurs prior to the stimulation of thirst. So your first response to slight increases in tonicity is to tell the kidney, stop dumping so much water, right? That's the first response. That's what we are usually relying on in our busy work days. The first thing is kidney hold on to water. And then if if that's insufficient, that's when you're starting to get thirsty throughout the day, right? So we don't typically get thirsty before our kidney is starting to hold on to free water. Now, vasopressin binds to V2 receptors. There are a lot of different vasopressin receptors. I alluded to this in one of our former conversations, that vasopressin has a very complex biology. There are vasopressin receptors that mediate vasoconstriction. There are some vasopressin receptors that mediate vasodilation as well. And then there are vasopressin receptors that mediate water reclamation. Okay? How does the V2 receptor regulate water excretion by the kidney? It's not just one mechanism, there are several mechanisms, okay? The one that we usually, that is center stage is, well, I'm going to dictate how much or how many aquaporin channels are inserted into the apical membrane of the collecting duct cells. So let's get that visual here. Here we are in the principal cell. There's also aquaporins expressed in the, again, the cortical collecting duct, the medullary collecting duct. Again, this is a regulated channel. The V2 receptor binds vasopressin, and that mediates the open probability of aquaporins. It increases the insertion of aquaporins into the apical membrane. You can see that there's also regulated water transport on the basolateral side through this aquaporin 3 channel. Again, V2 receptor binds ADH, regulating water flux. Okay, this is what we usually focus on when we're saying this is the effect of vasopressin on water transport. But I'll highlight another important mediator of water transport, and that is how much urea is packaged into the interstitium. So in order for water flux to occur, I need to open the channel, or I need to increase conductance of water. But the other thing that governs water transport is, what is the osmotic gradient for water flux? How many more particles are there on this side of the epithelium than this side of the epithelium? Okay, and that too is regulated by vasopressin. You can see that vasopressin increases the reclamation of urea, and so increases the tonicity of the medullary interstitium. That favors more water reflux. Okay. In fact, if you look at vasopressin antagonist studies, these are older papers now. Vasopressin antagonist was explored as a tool to use in managing heart failure patients, not just for hyponatremia, but even trying to get more water out of the heart failure patient, but primarily to manage hyponatremia. If you look at what happens to the urea in patients that were in these studies of vasopressin antagonist, the blood urea nitrogen concentration goes down when you give a vasopressin antagonist to a patient. So again, that emphasizes this maybe afterthought of vasopressin response. It not only mediates the conductance of water, but increases medullary tonicity to favor more water reabsorption. Okay, there's yet one more mediator of water reclamation, and that is how many particles are on the apical side or on the luminal side, right? One other way I can influence water balance is I can increase the number of particles in the tubular lumen. If I increase the number of particles in the tubular lumen, that would resist water reclamation. It would enhance the excretion of water. How can I increase the number of particles in the urine? Well, I can give you mannitol. right? That would be a classic osmotic diuretic, a filtered solute that is not reclaimed and therefore acts osmotically to resist water reclamation. Meaning, I may have open water channels, I may have plenty of urea that's packaged on this side, but if I have an osmotically active particle on this side, it would result in net less water reclamation. So mannitol causes, again, water excretion through this mechanism, even if ADH is high. You can cause hypernatremia. That's what our neurosurgery team is doing. And these patients that are hypernatremic in the neurosurgery ICU, their ADH is sky high. Yet you can still cause hypernatremia in those patients by giving mannitol because you're enhancing water excretion nonetheless by increasing the number of particles. Another way that is becoming, I'd say, more in vogue is the use of SGLT2 inhibitors. We seem to have an infinite number of excuses to give SGLT2 inhibitors now. Another one is to try and increase water excretion in patients that have SIDH. By blocking glucose transport in the proximal nephron, you cause glycosuria, and you're increasing the number of particles in the tubular lumen, and you're therefore increasing water excretion. And there's some small studies that show increases in serum sodium in SIDH patients treated with SGLT2 inhibitors. When we give urea tablets, we are essentially increasing the number of particles that you're excreting, your urea powder, I should say. When you're giving salt tablets, okay, you might say, I am raising sodium in my SIDH patient by just adding to the numerator of Edelman's relationship, but in fact, that's not what's happening in the chronic patient. A chronic patient, you will recall Edelman's relationship, serum sodium is equal to exchangeable sodium plus exchangeable K over total body water. You should be able to do this in your sleep now. You might say the sodium is going up by giving sodium tablets to a patient. I'm augmenting the numerator, but that's not happening because what happens when you and I take more salt in our diet? If we held on to that salt, we all get edematous. No, what happens when we take more salt in our diet is we dump more salt in our urine. So in essence, in a chronically managed SIDH patient on salt tablets, you also are increasing the number of particles that's on the luminal side, and therefore enhancing water excretion by giving salt. Salt enhances water excretion, and that's the mechanism of benefit in SIDH in the chronic phase. When you're giving hypertonic saline, you are augmenting the numerator. But when you're giving salt tablets in the chronic phase of SIDH management, you're increasing water excretion. Okay, let's get back to our discussion then. So I've made these points essentially. Vasopressin increases urea transport, increasing the medullary tonicity, and then there is an effect of vasopressin that we don't emphasize on sodium reclamation as well. We think of vasopressin as primarily regulating water transport. You now know it's regulating urea transport. There is an effect of vasopressin also on sodium transport, but that is a less potent stimulus than, for instance, ENaC. Okay, something to know, but is less physiologically significant. Okay, what are some of the triggers of vasopressin release? We talked about hypertonicity, which is distinct from hyperosmolality, right? You may have a BUN of 200 that causes hyperosmolality, but if your cells in that posterior portion of the third ventricle, the area of the hypothalamus, if they're not shrinking, because that's an osmotically inactive particle, then they're not causing vasopressin release. Now, you have to probably asking yourself, what is this guy talking about? He's saying that urea can function as an osmotically active particle, in some places, but it doesn't in others? Well, that is because you have urea transporters that are constitutively expressed in most of your cells that allow for that permeability of urea to occur. It's regulated in the collecting duct where urea can function as an osmotically active particle. Okay, that's how you reconcile those two statements. All right. Um, so hypertonicity is a stimulus. It's your main stimulus of vasopressin release. The other main stimulus of vasopressin release that we encounter in the clinical realm are the hypovolemic patients or those patients that are hypervolemic but have low effective circulating volume. The classic cirrhotic and heart failure patient, right? That is a very potent stimulus of vasopressin release, and that can outweigh the hypertonicity response, okay? That is, when that hyponatremic heart failure patient that you encounter, they should be shutting off vasopressin from a tonicity standpoint. But the reason that they are having water retention is that that low effective circulating volume is trumping the effect of tonicity on vasopressin release. Okay, so that makes sense. Maybe teleologically, right? If you're exsanguinating out in the on the steppe, right after a fight with an wild animal, your body's going to say, I need to retain volume to keep you alive, even if your tonicity is low. So I'm going to release anti-natriuretic hormones and anti-aquaretic hormones to maintain circulating volume, even at the expense of further deterioration or reduction in tonicity. Okay. These other things that we invoke are nausea and pain. I would say that in general, those should not be your only explanation when you encounter a hyponatremic patient. This is all nausea-induced vasopressin release. It's usually the sum total of multiple things. You can add these on, but I don't think we should sort of rely on these as sole explanations. Look for something deeper in most patients with disorders of water balance. It's usually not just just pain and nausea. Okay, those would be transient effectors. Pulmonary disease of any etiology, we don't understand why, can result in ADH release. We know these are some of the differential diagnoses of SIDH. CNS insults, including hemorrhage, stroke, and encephalitis, and even acute psychosis, are causes of SIDH. And so they show up as stimuli of vasopressin release. Pregnancy is a physiologic state in which vasopressin release is enhanced. This is a form of reset osmostat. Okay, so and that presumably again makes teleologic sense in preparation for delivering a baby where there is a blood loss. The mom is retaining extra volume both by anti-natriuretic hormones as well as anti-aquaretic hormones in order to expand blood volume in order to, again, prepare for the blood loss that may occur during pregnancy or during delivery. So pregnancy is a known cause of reset osmostat. Most females that get pregnant, you'll see a subtle drop in their serum sodium. Drugs can do this, particularly SSRIs, as well as carbamazepine and trileptyl oxcarbamazepine is again a stimulus of vasopressin release. And then imipramine is used for treating bedwetting. Presumably, again, the mechanism of effect is reducing urine volumes by stimulating vasopressin release in a child or who's has chronic bedwetting. Okay, glucocorticoid deficiency is another clinical context in which vasopressin levels may be high. Okay, so this corticotropin releasing hormone stimulates ADH release. Okay, so if I have glucocorticoid deficiency, I have high CRH levels. CRH stimulates ACTH, if you recall, which stimulates cortisol production. Okay. This explains why when you have adrenal insufficiency, just pure glucocorticoid deficiency, not even just, primary adrenal insufficiency, those patients may get hypovolemic because of the glucocorticoid and mineralocorticoid deficiency. Hypovolemia may stimulate vasopressin release. But even pure glucocorticoid deficiency, even if you're not hypovolemic, can be a stimulus of vasopressin release. And here is the mechanism, okay? Because CRH also stimulates the release of vasopressin. Okay? All right. Urine osmolality, okay, we're still under the heading of ADH. We're fleshing out the effect of ADH. Urine osmolality is your biomarker of how much ADH is present. Okay, we don't typically measure ADH. Now there's a literature on measuring copeptin, a cleavage peptide from the pre-hormone of vasopressin. It has a longer half-life, so some people have reported copeptin levels as a way to interrogate dysnatremia, but we don't do that much. We use urine osmolality. If your urine osmolality is high, that generally tells you ADH is high, okay? And with completely normal tubular function, we have a pretty large bandwidth for urine osmolality. When vasopressin is completely off, you can make an exceedingly dilute urine, 50 milliosmoles per kilogram. That compares to the normal serum osmolality of around 280, so very dilute, okay? And you can make a very concentrated urine, up to as much as 1,200 in a young kidney with intact capacity for concentration, okay? ADH, what am I trying to say here? Okay, I've made this point a couple of times at bedside conversations, as well as in other lectures that we've done. ADH is not the only determinant of urine volume. The main determinants of urine volume we've expressed mathematically. Hopefully you recall that conversation, but I'll just repeat it here. This becomes relevant as we flesh out the physiology of tea and toast hyponatremia, or beer potomania as another sort of similar physiology. Urine volume is determined by the 24-hour urine volume, I'll use that, the 24-hour osmolar excretion, right? So that's how much salt and protein is in my diet. That's in the numerator. And my average, let's say, 24-hour urine osmolality, okay, which is the units of milliosmoles per kilogram, but we'll use osmolarity to simplify that to milliosmoles per volume. That's milliosmoles per liter. That is the determinant of urine volume, okay? So, again, the denominator in that equation is regulated by ADH, right? So if I have inappropriate elevation in ADH, I have an inappropriately high urine osmolality. One way I can enhance the excretion of water and enhanced urine volume is I can inhibit the response to ADH, right? I can give you, for instance, a vasopressin antagonist. I can lower the urine osmolality by giving you a vasopressin antagonist. That will increase my urine volume. That's expensive and is only approved for short-term use, okay? Another way I can increase urine volume is simply by giving you more salt or urea, right? That would also, even if I don't change the urine osmolality, I can enhance water excretion. by increasing the number of osmoles that you have to excrete. Okay? So here is that numerator, sodium, potassium, salts, and urea. And again, urine volume is proportional to this urinary excretion of solute divided by urinary concentration, essentially. Okay? So when I have a patient who has high ADH and therefore has high urine osmolality, I can still develop hypernatremia, even though I'm trying to conserve water, right? By elaborating a very concentrated urine. I can still get into trouble with hypernatremia if this urine osmolar excretion rate is obligatorily high, right? So again, going back to this formula, even though I might predict if I have a high urine osmolality, my urine volume will be low. That may not necessarily be true if I have an exceedingly large number of osmoles that I have to excrete. When does that occur? We already went over one. When I give mannitol to a patient in the neuro ICU, even though they may have a very concentrated urine, you can create hypernatremia by obligating large amounts of osmoles that must be excreted through the administration of mannitol. The other, technically though, mannitol also does reduce urinary osmolality. It causes what we call a medullary washout. It increases medullary blood flow, administration of mannitol, and you do get some reduction in urinary osmoles when you give mannitol in the neuro ICU. But simplistically, I'm increasing the osmolar excretion, right? The other scenarios in which this occur are the burn patient getting really large amounts of protein, or TPN with large amounts of protein and salt. Those can also obligate large amounts of osmoles that one must excrete, and therefore large urinary volumes that may cause excess water loss. Okay, that is summarized as an osmotic diuresis, right? All of those are examples of osmotic diuresis. Okay. Similarly, on the flip side, even when urine osmolality is low, that means ADH is low, I can get into trouble with hyponatremia if my osmolar excretion rate is very low. Okay, that's the classic tea and toast hyponatremia. So again, in this scenario, I might have a very dilute urine. So urine osmolality may be low, right? If urine osmolality is low, something in a denominator is low, then I would expect my quotient to be high, my urine volume to be high, right? But it may not be high if my osmolar intake is very low. So I might have, for instance, a tea and toast hyponatremia where I have a urine osmolality may not be maximally dilute, but let's say it's a 80-year-old, which is the classic, elderly tea and toast hyponatremia. They can't go all the way down to 50 milliosmoles per kilogram. They'll go down to something like 200. And if they're taking in only 200 osmoles per day, an average being around 600 to 800, right? If they were taking in 600 to 800, this would mean they're peeing 3 to 4 liters of urine a day. But if that individual, without changing their urine osmolality, is only taking in 200 milliosmoles per day, their urine volume is only 1 liter. If the T is greater than 1 liter, the T intake that is, then they hold on to that water. And their serum sodium drops an infinitesimally small amount. You string several days together, a month of that. Every day, water intake exceeds water excretion a little bit, and then you come in with a sodium of 125. Okay? Stringing enough of those days together. Okay, moving on to thirst. The triggers for thirst are very similar. Hypertonicity, low effective circulating volume. Angiotensin also has a stimulus of thirst. So I've showed you how technically there is an effect of vasopressin on sodium excretion, right? An intersection of, let's say, the RAS system with vasopressin. You can see there is also, on the flip side, RAS system that is also stimulating or mediating water balance. So it's not so clean. We say vasopressin is all about water, RAS is all about salt. There is a little bit of overlap. Okay? All right. Edelman's equation, we've gone over. I think I can be pretty brief on this. This is the key to understanding dysnatremias. It is based on, empiric data that was published by Edelman in the Journal of Clinical Investigation. One of our fellows covered this as a historic journal club some number of years ago, and it's a pretty interesting paper to pull. And this is the relationship which we've gone over. It's a simplified relationship. If you look at the actual Edelman's equation, there is a slope term, right? If you simplify this to y equals mx plus b, this suggests that the m is 1 and there is no y-intercept. There is actually a non-1. It's, I think, 1.11 is the slope term, close enough to 1. And there is a y-intercept, but just for ease of utility, we drop those. Okay, and this is a simplified Edelman's equation. If you pull the original paper, you'll see that there is a slope term and a y-intercept. We've already gone over what does exchangeable mean, so I can just briefly say if that sodium can enter aqueous phase, whether it's in the cell or outside of the cell, in the cell is immeasurable in routine clinical practice, that's considered exchangeable sodium. Okay, so what are the dysnatremias in Edelman's terms, right? What are the common dysnatremias in Edelman's terms? A hypovolemic hyponatremia is an individual, if you're hypovolemic, your total body salt content is low. Okay? In a hypovolemic hyponatremia, this is hypernatremia, excuse me. We'll get to hyponatremia. So hypovolemic hypernatremia is a patient, if you're hypovolemic, your salt content is low, right? But if you're hypernatremic in that context, it means your water deficit exceeds your salt deficit. And so the quotient is increased. That's what a hypovolemic hypernatremic is. We've gone over this point, okay, a number of times. Most fluids, physiologic fluids, are hyponatremic or hypotonic. Okay, jumping ahead, here's the average electrolyte content of various body fluids. You can see that gastric fluid, it's sodium. This comes from surgical literature that's published. Sodium content of gastric fluid is 40. The potassium content is 10. Let's just add these together. So if the sum of these two is less than 150 or 140, let's call that hypotonic fluid. Okay, so you can see that gastric fluid is hypotonic fluid. So if I have a patient with an NG tube in, that's the NG suction, you should predictably expect that that individual is losing water faster than salt. In Edelman's terms, they will get hypernatremic because they're losing water faster than salt. And that happens. You should predict that. If you have NG suction and you want to prevent that, you should not put them on normal saline. You'll get hypernatremic. You should routinely put them on half normal saline. Okay. In general, these diarrheas that you're going to see, which is primarily these inflammatory diarrheas, if you add this together, this is somewhere around 120-ish. They're generally more more water loss than salt. Okay. Ileostomy that is established is going to have more water loss than salt. Okay. There are few exceptions which can result in hyponatremia. Okay. Simply by the loss of this relatively hypertonic fluid. If you have an individual who has a pancreatic drain in place, losing lots of fluid without taking anything in, this individual can get hyponatremic, okay? Because they're losing salt faster than water. Biliary drain, you can get hyponatremic in that scenario, okay? Newer ileostomies are still primarily going to be more water loss than salt loss, but you can see that the electrolyte content of a new ileostomy is higher than that of an established ileostomy. If you have an individual with Vibrio cholera, you can lose a fair amount of salt, and those patients can tilt towards hyponatremia even without taking in much water. So I've made this point multiple times at the bedside, and I'll do it again here. If you have a hyponatremic patient that comes in and don't have a pancreatic drain, a bile drain, Vibrio cholera, okay, even if they tell you, I was not drinking much, doctor, you'll have to say, well, you don't have to confront them and say, you are a liar. I banish you. You would just say, okay, but know that they are not telling you the full, they don't realize that they've been drinking water, because that's the only way, because all of these losses, sweat losses, right? Sweat losses, stool losses, right? They have exceedingly low amounts of electrolyte in them, okay? So if you're losing, breath, sweat, stool, a little bit of diarrhea, you're losing water faster than salt, and you have to get hypernatremic if you're not, even if you have SIDH. If you have an SIDH patient who is, who also has a G tube in and the G tube falls out, that SIDH patient's coming in hypernatremic. And they have high ADH, just like a water deprived individual. Okay. They have high ADH just like a water deprived individual. And if you're not giving them water, they're not going to get hyponatremia. Okay. Said a different way, every SIDH patient technically can be water restricted to normonatremia, right? If you had absolute control, but usually you don't, because they have a thirst response that's really getting in the way. Okay. So again, in Edelman's terms, hypernatremia with hypovolemia, the classic patient is a GI loss with impaired thirst response, would come in hypernatremic. Don't forget that as they're getting diarrhea, if you and I getting diarrhea and hypovolemic, we're going to get thirsty. And so we're going to start wanting to drink, even if we're not calculating that. Okay. Hypervolemic, hyponatremics, the classic cirrhotic heart failure patient or the nephrotic patient, those patients, if you're clinically hypervolemic, have a numerator that's big, okay? You have a salt excess. Even if you're hyponatremic, your salt content, even if your salt concentration is not high, your salt content is high. But these patients have a water excess which exceeds that salt excess. And so the net result is the sodium falls. Hypovolemic hyponatremics are patients that have a salt deficit that's exceeding a water deficit. So they have a quotient that's low. What are the clinical scenarios in which that can happen? Diuretic therapy, especially thiazide diuretic therapy, tends to cause a salt deficit that exceeds your water deficit. Loop diuretics, in general, cause you to lose more water than salt, and that's why loop diuretics are sometimes used for treating SIDH, because again, they generally enhance water loss faster than salt, But remember, this is a net term, right? So you have to take into account what happens to total body water is not just what the diuretic does, but also what their thirst response is. So you absolutely can give somebody a loop diuretic and their net water loss be relatively small, okay? Because this is a net that's important. So if I am, yes, I'm an enhanced water loss in my urine, but I also got more thirsty, the net effect can be my sodium is falling on a loop diuretic, okay? So diuretic therapy can make me lose salt faster than water. GI losses when I respond to that GI loss with thirst, right? If I'm vomiting, if I'm just vomiting, right, and not drinking anything, predictably that patient is hypernatremic. Okay, if they told you, doc, I couldn't keep anything down. Yes, you could, because you're hyponatremic. Again, don't shame them. You're telling me lies. You just say, okay, fine. You think you didn't drink much, but you had to drink in order to get here to be hyponatremic. Okay. All right. So the other patient that we'll highlight is the mainly just a big denominator. That's your SIDH patients, right? They have normal salt content, but they just have a water content that exceeds normal. Okay. Another concept we'll talk about, electrolyte-free water clearance. Okay. This is a formula that is a simple derivation from Edelman's equation. You can see that it has essentially many of the same terms. And so the electrolyte-free water clearance mathematically tells you, you tell me how much of your water or how much of your urine is simply free water. That's essentially what it's saying. It's saying your urine can be broken into two different components. Your urine can be broken into, this 3 liters that you're making of urine. Here, 3 liters of urine consists of isotonic urine, right? If this is isotonic urine, it means it contains the same amount of salt and water that you have, right? And if I'm losing this isotonic urine, it has no effect on my serum sodium. It's essentially saying that in Edelman's terms, this urine results in equal proportions of salt loss and water loss in Edelman's terms. So we'll say salt and water. And if I lose equal proportions of salt and water, I get smaller, but my sodium doesn't change. Okay. And then some amount of free water loss. That's essentially what you're calculating. You're calculating this when you calculate electrolyte-free water. It says of this 3 liters of urine, this much is isotonic and is irrelevant to the water, to the sodium concentration. This is all that's relevant, okay, in predicting what happens to the sodium concentration. If my electrolyte-free water clearance is positive, it means I am losing free water. My sodium is going to tend to rise. Just looking at it one-dimensionally, just looking at the effect of urine on my serum sodium. Okay. This is really a one-dimensional view. It's totally taken out. What is the water intake of the patient? What is the salt intake of the patient? Those also affect serum sodium. This is only looking at one dimension in predicting what happens to the sodium. Okay. You can also calculate an electrolyte-free water clearance and end up with a negative number. That's essentially saying that this urine that you're making is more salt than water and is resulting in a serum sodium that's falling. Okay. It's equivalent to generating free water. Okay. So let's go through these statements. When electrolyte-free, we often simplify, oversimplify. Already electrolyte-free water clearance is one-dimensional. I mentioned that. You may have positive electrolyte-free water clearance, which would predict sodiums go up, right? But your sodium is still going down. Well, the obvious explanation is, yes, I'm losing 500 cc's of free water in my urine, but I'm drinking 3 liters. So that would be a scenario in which I have positive free water clearance, but my sodium is still going down, right? Okay, we often even simplify it even more and become further from the truth. We often say, well, if my sodium in my urine and potassium in my urine, if I add those together, and that is a number that's smaller than my plasma sodium, this number, this fraction will be less than 1. If I subtract a fraction less than 1 from 1, this will be a positive number. I would say, regardless of my urine volume, my electrolyte-free water clearance is positive. Okay, and then we often say, don't worry, my electrolyte-free water clearance is positive. Sodium's going to get better. Okay, consult done. Sign off really early. Okay, and then you get reconsulted. My sodium is going down. You guys are liars, and then they shame you. They say, you told me electrolyte-free water clearance is positive, the sodium's going down, and you signed off too early. So reconsult the fellow who's trying to keep their list too short. Okay. So that's all too familiar, right? Okay, so the point I'm trying to make is don't forget the urine volume matters. And the most potent example of this is in the oliguric patient, where I often say, okay, when you have a hyponatremic oliguric patient, you don't have to come up with fancy explanations for that. It doesn't matter what their ADH is. It doesn't matter what their response to ADH is. If you're oliguric, this number is small. Okay, and so your electrolyte-free water clearance is small, no matter what your urine electrolytes look like. And so you can just jump to the punchline: hyponatremia, etiology, AKI, management, fluid restriction. Okay, don't tell me, well, this is hypervolemic, hyponatremia, blah, blah, blah. That's not relevant, okay? Just oliguric AKI, okay? So don't forget, there's a volume term, and that matters. You can have relatively small electrolyte-free water clearance if this number is small, and also if this number, this fraction is 0.9, then 1 minus 0.9 is a positive number. It's 10% of my urine volume. If I'm excreting 10 liters of urine, only 1 liter of that is free water clearance. So that may still be relatively small. Okay, so magnitude matters. Okay, we often just say this is a positive, negative. It's a binary thing. Positive free water clearance, boom, consult done. Magnitude matters is the point I'm trying to make. Okay, when, again, you can have negative free water clearance. I've already said that. Magnitude matters is the point I'm trying to make. Okay, we have 4 more minutes here. Are we good to move on? Any questions? Let's talk about pragmatic evaluation of hypernatremia then. Okay, so if somebody is hypernatremic, they have to have a problem with thirst response. Okay, said a different way, put into a clinical relevant scenario, is diabetes insipidus patients don't present hypernatremic, they present with polyuria, okay, or polydipsia as a chief complaint, right? They have a problem with vasopressin response or vasopressin action, okay? But they don't get hypernatremic because they have an intact thirst response and they just start drinking. Okay, and so in order to get hypernatremic, you have to have impaired thirst response. Okay. Um, because again, otherwise my brain is going to tell me to drink. Okay. Um, and Did you and I take care of this interesting patient, young lady who came in with some mitochondrial disorder? Yeah, and she had a multi-system disorder that predisposed her to lactic acidemia, and also came in with hypernatremia. And she supposedly has the mental capacity of a child, and she came in with a sodium of 160. And we asked mom, and dad said, does she is she acting normally? Yeah, she's acting normally, meaning she's not totally altered. And then you ask, well, was she telling you she's thirsty? No, she's not telling me she's thirsty. That tells you that not only did this patient just come in volume depleted from, again, excess water losses, we'll spare the details of how she got water losses, but she also has an impaired thirst response, even when she's supposedly normal. Because again, you can't have a sodium of 160 and not be thirsty. Even a child would tell you that, right? People who have kids will understand that I'm thirsty, right? Yeah, they don't just say, I'm hypernatremic. Okay. So, again, thirst response is important, right? What are the impaired thirst responses that you encounter? Well, somebody who can't, drink, or they can't hold it down, right? Because they're vomiting. Or they are basically, sedated. They're, out in the elements. They're demented. And then you can have the adipsic patient. Remember, we talked about that thirst center that can be impaired. And we had a couple of interesting encounters in recent months. I think Kelly and I had a patient who had profound adipsia. And these patients are interesting. The adipsic patients can come in profoundly hypernatremic because they too are a story of their water excretion is a little more than their water intake every day. And so their sodium just ticks up a little bit every day. And they can be very well compensated with a serum sodium of 170 in these patients with adipsia, because it just happened they just don't have a thirst response, and they just got a little bit hypernatremic every day. And that's kind of what happened in the patient that we recently encountered, who I mentioned was a patient I had first took care of years ago, who had outpatient labs, and he looked totally fine, and then I got called when he went home, serum sodium of 170. Call him and come back in, let's get you tuned up, right? But he looked fine even with a sodium of 170. Those are interesting patients. And then there's some patients who really just don't want to drink because they pee too much. Okay, I'll categorize that as an intact or an impaired thirst response. All right. Step 2, you might just quickly measure the electrolyte-free water clearance, or calculate the electrolyte-free water clearance to see if there's an appropriate renal response to this hypertonicity. Most patients should have a negative electrolyte-free water clearance in that scenario. If you're responding normally, the kidney is responding normally. Often I would say, we take a shortcut. We just look primarily at the urine osmolality. That should be quite high, but more holistically, your electrolyte-free water clearance should be relative, which should be low, if not negative. Okay, and if I have abnormal electrolyte-free water clearance, especially urine osmolality, you got to understand the factors that alter this normal physiologic response if these don't make sense in the setting of urine osmolality. Okay, so we'll talk about those. Yeah, maybe I'll end it there.